Thank you, Devashish. A very good morning to you all. Thank you, chairpersons. Devashish has very kindly put me as the opening batsman for this conference. I'll certainly attempt to do a better job than our boys down under in the T20. So the late TGA, what strategy and when? This is a topic of special interest to me ever since I started my career in pediatric cardiac surgery. So to start off with, we need to answer the question, what is late TGA? And as we are all well aware that the surgery of choice for transposition intact ventricular septum in the current era is a primary arterial switch performed within the first few days of life. In fact, in the US, probably they would like to do it within the first 2 to 4 days because of monetary issues, because the study showed that if they operated a patient even at 8 to 14 days, the hospital costs almost doubled to over $200,000 in comparison to $125,000 if they do it within the first 2 to 4 days. But certainly in this part of the world, in our country especially, delay in referral as well as late diagnosis is often the norm. So it's not uncommon to find patients coming in much beyond the so-called recommended time for a primary arterial switch. And we're all well aware that the left ventricle tends to involute with time in transposition intact septum, especially once the duct closes and there's decreased afterload. The left ventricle tends to get deconditioned and then eventually loses LV mass. And this is not a new phenomenon. This was studied as way back in autopsy studies in 1984. As you can see that in the normal heart, the left ventricular wall thickness continues to increase along with time and age. But in transposition, the left ventricular wall thickness remains almost static, although the patient grows. So there is relative deconditioning and loss of ventricular mass in the left ventricle. So eventually the ventricle begins to look somewhat like this, a banana-shaped ventricle. On cross-section, the interventricular septum moves with the RV rather than with the LV. And it's also confirmed on electron microscopic studies, the study with Dr. Bisoi's group from All India Institute, but they showed that in a deconditioned left ventricle, there is sort of loss of the regular myofibril arrangement and increase in the glycogen as well as the collagen content in the ventricles. But there are very many factors which affect regression or non-regression of the left ventricle, and especially a balloon atrial septostomy tends to rapidly increase the rate of regression of the left ventricle. And likewise, on the contrary, if the ventricular atrial septal defect is restrictive, then it probably protects the LV from regression. But in most cases, we really have unknown factors why certain ventricles tend to regress very fast and some don't. And the study very elegantly from Sri Chitra Institute down south showed how the left ventricle can very rapidly regress after a balloon atrial septostomy. So the corollary is that one should try and avoid a balloon atrial septostomy as far as possible in order to protect the left ventricle. On the contrary, in certain situations like this, a collateral flow in a transposition intact septum can keep the left ventricle preserved. So in this patient, we could actually do a safe arterial switch at 3 months despite the age. And then there are certain instances like this, a 3-month-old patient where we had absolutely no reason as to why this ventricle remained so perfectly prepared even at 3 months of age. Now, what was the impact of the age in terms of surgical outcomes of the arterial switch? And the early data from the CHSS in 1988, and they came up with this graph which has stuck all these years. It basically showed at that early experience that there was an inflection point at about 2 weeks of age where the mortality rapidly increased when patients were operated later in the time course of event. So the mantra at that time, which was announced, was that 2 weeks is sort of the upper cutoff, maybe 3 weeks to do a safe primary arterial switch. And then patients who were presented beyond this age were subjected to a staged arterial switch with prior left ventricular training. And so they fell back on the original Jakob's technique of staging the left ventricle, where he initially described banding of the pulmonary artery along with a Blalock Taussig, not a Blalock Taussig shunt, an aortic pulmonary shunt proximal to the band in order to deal with these patients who in those days did not present in the neonatal period, but presented later. But then with more studies, which on the experimental lab demonstrated the fact that a neonatal myocardium This was studied in mice, would show a very rapid increase in ventricular mass when subjected to an afterload by means of a PA banding, that within a few days itself, that the ventricular mass could almost double, and this is related to rapid increase in the RNA polymerase activity and increase in the cellular RNA. And so that gave rise to the rapid two-stage arterial switch, which was initially described by the Boston group. And the patients who presented beyond 3 weeks of age were then subjected to a rapid two-stage. And then they showed in their clinical study also that the same phenomenon occurred in babies, that there was a rapid increase in the myocardial mass, left ventricular myocardial mass, when subjected to a pulmonary artery band, so that the second stage of conversion to the arterial switch could be done within 7 to 10 days after that. And we also, when we were at the All India Institute, joined that bandwagon. And this was our initial experience between 92 and 95. And we had a series of 32 patients. The results were not too bad, but not too good either. We had a 75% successful conversion to an arterial switch, but there was a 15% mortality. At the same time, there was also the realization that the left ventricle failed following arterial switch, not because it was always regressed, but there were other causes also, which could possibly be corrected, like, for example, poor myocardial preservation, or more importantly, inappropriate pharmacotherapy in the postoperative period. And with that understanding, then it became also necessary that all patients who are undergoing an arterial switch, irrespective of age, should have a backup for a mechanical support. And so then there was attempts to extend that boundary, and that mantra of 2 to 3 weeks for a time limit for primary arterial switch began to get broken. And there were many groups trying to extend the boundaries of the primary arterial switch. And this was an initial landmark paper which came from the Great Ormond Street Hospitals for Sick Children. And they compared the outcomes in patients who were operated late vis-a-vis those operated in time. And you could see that this group of patients between 21 and 185 days, the operative mortality was no different. And also the use of ECMO in these two groups was no different. And therefore, they concluded that the left ventricle remains adaptable and maintains the potential for systemic work well beyond 3 weeks of age. And although there is a period of low cardiac output syndrome, which needs to be tided over. So subsequently, there were very many publications which came detailing the outcomes with delayed primary arterial switch. And you can see that in most of the groups, there was no difference between mortalities in the early group and late group. Of course, there was a need for extracorporeal membrane oxygenation in both the groups. And in most of the experiences, there was no statistically significant difference between the two. And we also at the same time ventured into seeing how far we could extend the concept of primary arterial switch. So between 2007 and 2009, we did a sort of a preliminary study in trying to take on these patients who presented beyond 3 weeks of age up to about 3 months of age, trying to push them as far as possible with pharmacological therapy and trying to avoid ECLS. And so that was an initial pilot study with 25 and 22 groups in both groups. And our essential aim was to try and modulate the pharmacotherapy in the postoperative period, trying to gently cajole that left ventricle in the postoperative period from a state of deconditioning to a state of conditioning. And essentially, just a few slides to show what the course of these patients were. So this is a typical patient who presented with left ventricle, which is regressed at 58 days of age. And that immediately after the switch, you can see that the heart is extremely tachycardic, the left ventricle is dilated with somewhat reasonable contractility. And that's the time course of the patient's hemodynamic parameters. The first couple of days are fairly stormy with low mean arterial pressures, highish left atrial pressures. But as time goes, the arterial pressures improve, the LA pressures come down. Sternum is usually open, can be closed by the 5th postoperative day. By 6th or 7th postoperative day, extubated to CPAP. And they usually can be discharged by 8 to 10 days. And this is what this sort of chart looks like. Sometimes it can be scary, but it needs to be tided over. So you can see a mean arterial pressure of 29 and LA pressure of 11. This on the first postoperative day. by the next few days, you can see that the mean arterial pressure gradually improves. The LA pressure remains steady. By the time they reach the 5th postoperative day, the good arterial pressures, LA, come down to well below 6. And you can see that the ventricle has substantially improved by the 5th postoperative day. And by the time the patient is getting ready for discharge, you've got a mean arterial pressure which is in the 70s. And then that's the patient at the 8th postoperative day, ready for discharge. So in that initial group of patients, we had comparable operative mortalities in both. We didn't lose any patient because of a left ventricular dysfunction. And so we continued the protocol. And then between 2002 and 2019, those were our outcomes. 274 patients who underwent a primary arterial switch, and compared to the group which was beyond 3 weeks of age with a median of 54 days, the mortality was 4% in comparison to 6.8%. There are 2 patients in either group who required mechanical support. All 4 survived. So then we have continued with this policy. And if you look at what the recommendations are now, this is the ESCTS recommendation that a primary arterial switch should be considered up until 60 days of age with ECLS backup. What happens in a patient presents beyond 3 months of age? So in there, again, we have 2 options. You can go down the arterial switch pathway, or the second option is an atrial switch, because the atrial switch has no age limits, and you can safely perform it at any age. And when you're considering an arterial switch, then you need to determine whether that left ventricle requires retraining or does not. And here it becomes important to look at the echocardiographic parameters of the left ventricle. And there are very many parameters which are stated, which are listed here. The left ventricle being banana shaped, and more importantly, the posterior wall thickness, if it's less than 3 millimeters, and diastole, a left ventricular mass of less than 35 grams per meter squared. And these are all sort of stated parameters. There's some hemodynamic parameters. If you're cathing the patient, RV, LV pressure ratio of less than 0.7 would be considered unsuitable. And some people have tried an intraoperative response to a trial PA banding. But most important that none of these are foolproof. And you've seen either patients who fit the criteria not doing well. On the other hand, patients who do not fit the criteria having a very smooth postoperative course. And therefore, by and large, we do rely a lot on eyeballing. If you're thinking of left ventricular retraining, then again, the retraining can occur before the arterial switch, which is usually in the form of a band and plus minus a PT shunt. If the patient has a PDA, or PDA can be recanalized, and that's another approach, is to stent the PDA, give the left ventricular volume loading and prepare it. All these work. And if you're doing it after the ASO, which is called the delayed primary ASO, already talked about the pharmacological, but then the other option is to do a LVAD and ECMO. But unfortunately, when the patients are beyond 3 months of age, then these maneuvers are less likely to work rather than in patients who are less than 3 months of age. The All India Institute group did publish their results of patients with the ECMO support in patients up to 3,000 days of age. But then, unfortunately, the mortality is substantial, 9.2%, and there's a 20% recourse to ECMO in this group of patients. One can also use LVAD, which is probably a better alternative, and these patients require longer-term support. And this was the paper published by the Mumbai group. So this criteria has also been incorporated into the guidelines for the management of transposition great arteries, and specific guidelines, especially of how the retraining of the left ventricle should be done in the 2-stage arterial switch. Emphasis on slow retraining, that means not elevating the left ventricular pressures too much at the time of pulmonary artery banding. There's not too much experience world over on the 2-stage arterial switch, but this is a recent publication from China where they analyzed 109 patients over a period of 11 months, where the patients presenting late, they considered 78 patients to have an adequate LV and underwent a primary ASO, and 31 patients who were a mean of 6 months having a regressed LV and underwent a 2-stage ASO. But what's important to note was a substantial increase in the early mortality, although they said it's statistically not significant, but more importantly, a very high late mortality in this group, and also a high incidence of late aortic regurgitation. So although the 2-stage arterial switch is an option, but it's not a very favorable option. There's also a concern about the late left ventricular function after retrained left ventricle. Again, we do not have too much data available in detransposition. There is some data available in late LV function following retraining in CCTGA, where it's been shown that there is definitely impact on late left ventricular function when you retrain these ventricles. However, there is concern about increase in neo-aortic regurgitation and possibly an increase in the right ventricular outflow obstruction. Certainly in our own, this is an anecdotal experience, but this is one of the first rapid 2 stages that I had done in the institute almost 27 years. And unfortunately, this patient has, after 27 years, a left ventricle that looks like this. So again, not too favorable in the long term. And this is only one of the studies which are available on the long-term follow-up of the 2-stage arterial switch. And this is a group from Netherlands. And again, you can see that they have shown that following a 2-stage arterial switch, there is a significant increase in the aortic neosinus, Z-score of +7. And you can see that cineangiographic film, the substantial dilatation of the aorta. So this, not only is this a concern, but then the secondary compression of the pulmonary artery, the pulmonary annulus does not grow as well as in normal. And although this is as yet not clinically relevant, but there's a potential for that to worsen over the course of time. So then we need to go back and see whether we still have a relevance of utilizing the atrial switch procedures in these late presenting transposition of great arteries. And though we know that the Senning is a physiological repair which leaves the right ventricle as a systemic ventricle, but the important thing is that it is applicable to all ages at present. It's a low-risk surgery with low intensive care. And those factors are important in that it still remains relevant in emerging economies. And we really need to see whether this operation should really be condemned as it has been. And so we have persisted with doing the Senning operation in these late presenting switches, experience of 125 to 2019. And you can see that the operative mortality is significantly low. What we have done now is to add a pulmonary artery band for these patients at the time of the Senning. And the theory behind it is that this moderate pulmonary artery banding would allow a slow left ventricular training. And we know that when the left ventricle in a Senning setting is near systemic pressures, the IVS remains in the midline, and that's an important contributor to protecting the right ventricle from right ventricular distension and failure. So the theory is that just the band alone might delay the onset of TR, just the way that PA band helps in patients with CCTGA. And then if the patient has a right ventricular failure node, it's likely that that left ventricle will remain prepared so that you don't have to retrain that left ventricle and you could proceed with an arterial switch operation at that time. So for the last 6 years, we've been doing a pulmonary artery band in these. There's certainly initial evidence to show that the right ventricle remains preserved. We haven't converted any to an arterial switch as yet because the patients are doing so well. The parents are reluctant to go in for a next surgery, but then we hope that this theory will hold true in the long term. And there's certainly a change of mind from the originator of the 2-stage arterial switch, Dr. Mark Diakub, and this is the latest paper from his report that there should be a revival of the atrial switch for the patients who are presenting late. And he's actually suggested some modifications to the mustard operation, giving the theory that the left ventricular inflow is as important in the long-term survival of these patients. But certainly, as he says, that in late presenting patients with TGA, the improving pattern of LV filling will enhance the long-term results with the atrial switch. So with all this data put together, our current approach to a patient presenting with late TGA, that if it presents before 2 months, we would do a primary AS. So irrespective of what the left ventricle looks like on echocardiography, if it presents beyond 6 months of age, then we do a Senning procedure with a pulmonary artery band. And between 2 and 6 months, it basically depends upon what the left ventricle looks like on echo. If it looks favorable, then we would do a delayed primary. We would do it with an ECMO backup. if the LV is unfavorable, but the resources, both in terms of parental consent as well as institutional resources availability, we would do an ASO with an ECMO backup. But if not, then we would do a sending with a PA band, which we feel is a much safer option. The two-stage arterial switch is no longer a favored approach in our setting. So to summarize, late presentation in TGA is an important problem in resource-limited countries. A primary ASO appears feasible up to 3 months of age with a low need for mechanical support. Beyond early infancy, the sending procedure compares favorably with the two-stage arterial switch operation, and the long-term outcomes of ASO, when available, will help in our decision-making towards this. Thank you very much for your attention.